Hey everybody, this is Ashley, week 3, and I'm going to be presenting AFI and EFW to everybody today. Alright, so when we're talking about AFI, we are talking about the amniotic fluid index. And so this is a number that is going to give us some within the pocket of the amniotic fluid that is within each of the 4 quadrants, which is then going to give us this average number to tell us whether the baby has adequate fluid in the sac or not. The AFI measurements started back in 1987, and when they first started this was looking at term pregnancies, and it was just helping to determine fetal well-being, and then it has developed into what it is now today. As far as EFW, EFW stands for estimated fetal weight, and so just kind of like it says, this is an ultrasound estimation of how much the fetus is weighing. And I couldn't find much history on estimated fetal weight. So when we're talking about our indications, so for our AFI, ACOG has put out a position statement in 2021, and it talked about antenatal testing. Both statements were correct for both AFI and EFW, and that we do this in antenatal testing because we're hoping to decrease the rates of stillbirth. When we talk about indications for the amniotic fluid index, there's a lot of different categories that things can fall under. So these things here are going to be the main reasons. If you do open the notes section of this slide, there should be some more information in there for you. However, things that we would be looking at in AFI in pregnancy is going to be somebody with gestational diabetes or pre-gestational type 2 diabetes. And we're going to be looking because those babies are at increased risk, or the moms are at increased risk of having polyhydramnios. We're going to want to look at chronic hypertension patients because they also have a risk of potentially having oligohydramnios. Moms who have preeclampsia, who have cardiac disorders, seizure disorders, and then also if there's maternal trauma. If there's a trauma, we may want to do an AFI just to make sure that there's not any type of leaking of fluid. And then for the fetus, if there's different anomalies that might indicate that we need to do AFIs, depending on what it is. If the baby has hydronephrosis or anything to do with their kidneys, very likely we'll want to do AFIs because the fetus is the urine is, they're getting their output is going into the fluid. And if there's something wrong with the baby's kidneys, they might not be putting out enough. They might be putting out too much. So we'll want to make sure if there's any baby kidney issues, we'll want to be watching AFI. And then as far as the placenta, if they have something like an abruption, they have chronic hypertension, smoker, or if you have a non-reassuring NST or fetal monitoring, you may want to have AFI to go along with your whole picture for your differentials. And then if you have leaking of fluid and you're at a facility or at a place where you don't have the ability to do any of the other testing, such as burn testing, amnisure, nitrazine, things like that, or obvious gross rupture of membranes, you might be able to do an AFI to determine if the water has broken. But again, this would be only if this was something that would change your plan of care. As far as EFW goes, we would be wanting to look at the estimated fetal weight for babies who have who we've identified as fetal growth restriction. Maybe the fundal height is not appropriate, or they're measuring too big. Gestational diabetes and pre-gestational diabetes are at risk for macrosomia, so we'll be watching this as well. Depending on the control of their gestational diabetes and mixed in with their fetal weight, their AFI, then we would be looking at delivery plans. If you have multi-fetal gestation, we want to make sure we're not having any like twin-to-twin transfusion, inappropriate weight distribution, those kinds of things. And then some fetal anomalies, we want you to watch the fetal weight. And then you can also do this once they get past their due date if we are continuing expectant management. All right, our contraindications. As far as AFI, the biggest thing is you can't do an AFI before the 20th week of pregnancy. And then after that, there's really no contraindication to an AFI. It just may not change your plan of care. And same with EFW. There's really no change to your plan, as long as there's no change to your plan of care, there's really not any contraindications of why you should not be doing this. All right, and as far as the procedure itself for the AFI, you're going to think of the maternal abdomen into four quadrants. And what they're going to do is they're going to look for the deepest pocket where there's no fetal parts or cord and measure that. Then they're going to add each of the four quadrants, and that's going to, and then they'll do the equation, and that's going to give you your AFI. As far as your estimated fetal weight, it's a calculation, and so they're going to look at several things. They're going to look at your gestational age, race, the bipyramidal diameter, the OCF, abdominal circumference, and thigh or femur length. Excuse me. They'll put all those measurements into a calculator, and it will give you your fetal weight based off of an average percentile across babies of the same gestational age. Advantages of being able to do an AFI are that when using AFI, the book did cite that we're able to look at the fetus using less interventions, but we're not having decreased outcomes. So it's low risk for it's an intervention that may prevent us from having earlier C-sections, earlier inductions of labor, earlier interventions that may affect our outcomes. The AFI measurement is also included in the biophysical profile that happens with fetal well-being, so that's an advantage. It's very non-invasive, just a outpatient, and so that makes it easy on the patient. And then the only disadvantage to this is that you also obviously have to have ultrasound access, and in some rural sites, this is not feasible 24/7 to have ultrasound coverage. And then as far as our estimated fetal weight, the biggest disadvantage is that there is a very large margin of error, especially the further into gestation, third trimester. When we're looking at our interpretation for AFI, excuse me, we're going to be looking at that single pocket again, and that pocket needs to have no fetal parts, no cord, and measuring the depth. And in a normal finding, this needs to be between 2 and 8, and then your AFI measurement based on all of that needs to be between 5 and 24. And then as long as we have that, there's no need for follow-up. An abnormal result is going to be classified as oligohydramnios or polyhydramnios. Oligo will be low fluid, poly is high. So if the fluid volume in the single pocket is less than 2 and the AFI is less than 5, then this would be diagnostic of oligohydramnios. And again, if a single pocket is greater than 8 and the AFI is over 24, this would be polyhydramnios. Both of these abnormal diagnoses will need follow-up because depending on how it's trending, how the baby is looking, maternal conditions, fetal conditions, that may change your plan of care. And then as far as estimated fetal weight, when you're interpreting the fetal weight, we have to also be cognizant that there is that large margin of error, and a normal fetal percentile is between 11 and 89, so it has a big range. The big things we want to look at as far as the abnormals is we're going to be looking for a baby who we're thinking is at risk for macrosomia, and we're going to be looking at that percentile be above the 90th percentile and seeing what it looks like. We're going to be looking at the fundal height as well, kind of going all together. And then we're also looking at that percentile, if they're less than the 10th percentile, then we're going to be worried about them being having small for gestational age or even IUGR, that intrauterine growth restriction. Either of these abnormal values will also need follow-up just to make sure how the baby's trending, what things are looking like, and what our plan of care is. And as far as our teaching, it's going to be very similar to for both things. We need to just explain to the patient, this is an ultrasound. It's an external probe, nothing going inside the body. This isn't painful to you. It isn't harmful to baby. The provider will go over all the results with you. And then based on the individual circumstances, what their results are between AFI or EFW. There may need to be follow-up, but all that will be conveyed to the patient once the results are in and the provider has been able to go over it with the patient. Here are the resources that I was able to use. And for anybody interested, ACOG has a really nice like 2-page handout or print off that talks about antenatal testing, AFIs, EFWs, maternal and fetal conditions, and when we should start doing that. And for that one, let's see, it is this indication for outpatient antenatal fetal testing. It was a good article. All right, I hope everybody has a great night and that answered all your questions.